compared to the research in Europe, whereby the frailty is only less than 10% and the robust or fit conditions is more than 40%, nearly 50%. So with this research, I think we have a lot of things that has to be done to combat this gap. Not only fear of falling after the event of falls, but the fears of walking later on. And at that time, the fear of walking with provide the consequences of isolations as well as depressions in the later life. So this issue sometimes neglected or out of the attentions of the carers. This inability to do the daily activities, hallucinations, and paranoid ideas or risk of falling, at the end, it will increase the need of carers, the time, the patience, and the energy to look after the loved ones. And of course, the need to be engaged in the family activities, which is also a good thing, actually. This would add to the carer's stress, frustrations, and also the carer's burden. Another issue that I would like to share is the BPSD itself, the behavioral and psychological symptoms of dementia. The apathy, lack of initiative, dysphoric or negative phoria, the irritability, anxiety, the delusions, as I have mentioned before, as part of the psychosis symptoms, the aggression, agitations, and hyperactivity. Those are symptoms that exist in patients with dementia sometimes. And those with the BPSD will quite often come to our attentions due to the screaming, to the restlessness all over the day, especially in the evening, the embarrassing behavior or the wandering. And to add to that issue is the harm or injury of the caregiver, not only psychologically, but also physically due to the aggressions and agitations. So those of unmet needs of the patients with dementia that represented in the symptoms of BPSD, of course, it will add to the caregiver's stress and frustrations. And if they cannot cope with this issue, it would influence the quality of life, the quality of care of the elderly with dementia. Another important issue for people with dementia is the functional disability that will come to the stage whereby they always need help in eating, in having meals, help in drinking, in using toilets, in transferring process from the bed, and from mobilizations, from walking. They always need to be helped in this basic activity of daily living. So they will need more help and assistance in most of these activities. So it is going to be a very huge task for the carers and the family in taking good care of their loved ones. It takes more time, more energy and psychological resistance. And also there is a loss of opportunity of the caregivers in productivity, of course. This is a research a report from the research from Australia and China of the family caregiving challenges in dementia care. As you can see here in both countries, the issue of caregiver distress, time dependence burden, physical burden, social burden, as well as emotional burden exists in these two settings. So regardless of where our elderly are, the same problem emerged in terms of the caregiver's burden. The last issue is regarding the comorbidity. As have already mentioned by DY lately, that the diabetes, hypertension is an independent important risk factor for dementia. But unfortunately, these two diseases also could coexist in the later life of patients with dementia. Not only that, coronary artery disease, dyslipidemia, Parkinson's disease, incontinence due to urinary tract infections, respiratory tract infections, depressions, and malnutrition would also be as a comorbidity in patients with dementia. Moreover, it will put our patients towards the needs of probably polypharmacy. difficulties in managing further the activity of daily living, managing the mood, how to reach the necessary food consumption and fluid intake. And also it will need more time for the family to be engaged with the patients for the family activity as well as social activity. Of course, we cannot deny this is a huge task that should be paid attention to. This is a research of the comorbidity burden of dementia, a hospital-based study for 8 years in 7 cities in China, comprises almost 3,000 patients with all kinds of dementia. And it reveals that the diseases like stroke, hypertension, diabetes, coronary artery disease, chronic pulmonary disease, hemiplegia or paralysis, cancer, congestive heart failure, even psychosis and depressions coexist in these patients with dementia, any kinds of dementia. So it's quite the same as we have here in Indonesia. The more severe the dementia is, then the average annual Medicare expenditures also increase. Regardless of the level of dementia, actually, the more the number of the comorbid, the cost will also be increased. And also, the more the older the patient is, the length of stay for the patients to be hospitalized due to that various medical conditions would also increase. Our study just lately also represents that the comorbidity of hypertension, diabetes, dyslipidemia, and chronic kidney disease quite also the same majority of diseases that coexist with the patient with dementia. So to end this presentation, and we have the opportunity to have discussions later on, that I would like to share that actually the prevalence of dementia in Indonesia increased concordance with the increased number of elderly population, as already mentioned by Dwi. The people with dementia are not only suffers from their cognitive decline, but eventually the loss of functional ability will be of more debilitating. The clinical features of behavioral and psychological symptoms of dementia are the most devastating problems endured by the carers, both caregivers and the family. Injuries, psychosocial distress, and loss of productivity are among some of the serious consequences that would be put on the carer's shoulders and family. Cumulative chronic diseases as the risk factors of dementia, as well as the comorbidity, will in turn add to the complexity of the problem faced not only by the patients, but also by the family. Knowing the burden of disease and the progression of the disease, early detection and prompt follow-up in a comprehensive manner will be the most effective way. Indonesia, with its huge number of elderly distributed in its 13,000 islands of archipelago, would face a challenging effort. But it is possible to take care of this issue. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sreshna, who very exclusively elaborate. Dementia is not just only cognitive decline. So there are various issues of functional disability, various issues of comorbidity. And we'll go to the last speaker, Dr. Vasontara. Could I have the profile? Susie?
Good morning, everyone. Can you hear me okay?
Yeah, okay.
Great, yeah. Thank you very much, the moderator, and good morning, everyone. The core symposium speakers and distinguished delegates. It's my honor to be part of the session today, and I'll be presenting about the depressive symptoms among caregivers for older persons and discuss some implications for long-term care in Asia. My name is Vasontara, Vas for short, and I'm originally from Thailand, and today I'm presenting on behalf of the Australian Centre for Excellence in Population Aging Research. Just briefly to introduce our work. So in this session, we just started SIPA and Aging Asia Hub in the University of New South Wales. In the last couple of months, we just starting to coordinate a commission book entitled Health and Long-Term Care in Emerging Asia, Health, Aging and Social Transition. And we had authors from Indonesia, from Bappenas, Minister of Health, in Thailand, from Mahidol University, and from Vietnam National Economics University. Long-term care, as previously discussed in earlier sessions, in our context, we talk about three broadly defined settings: at home, at community, and institutions. And that includes both medical as well as social care services, including the assistance with daily activities and other social support. In the context of emerging economies, family care is the most common. And these presentations, we will focus on home care and investigating depressive symptoms. So this is based on paper with Dr. Rihanna, Professor Cumming, and Professor Pickett. Actually, Professor Pickett also part of the APRU since quite the beginning, and he just sent his best wishes for the conference as well. I will start first with the World Health Organization 2020 to 2030 Decade of Healthy Aging. And this focuses on the process of developing and maintaining functional ability that enables well-being in the older age. And this is not only determined by individual intrinsic capacity, but also by the environment, which is home, community, and broader society. As you can see from this graph, if the older person is healthy, have a high stable capacity, the health services required will be more preventive care. But for those that have a decline or significant loss of decline in their functional capacity, so both medical health services as well as non-medical health services are required in order to for them to maintain their functional ability and also the dignity despite of this physical and cognitive and other mental health decline. Just briefly to show the projection of the United Nations population divisions. In the low and middle income Southeast Asian nations, the average of older persons aged 50 years and over would be on average over 15% in the next 15 years on 2035. You can see here the three examples that we put here is Indonesia would be 16%, Vietnam is 20%, and the Thailand is almost 30%. So the shrinking family size and increased labor participation has placed unprecedented demand on the traditional role of family care provision for the elderly. And as the plenary session mentioned, that the chronic non-communicable diseases are actually one of the most common causes, and those conditions require comprehensive and continuation of care. So in many low and middle income countries, the social welfare is still quite limited. And in this context, family care is still common as a cultural norm. Just briefly to touch on the international literature on family caregivers. So multi-generational co-residencies between older persons and their adult offspring is a common family attribute. And they're helping not only physically, but also emotionally, socially, and financially. So psychological health is actually one of the most important issues due to its direct effects on caregivers, such as the burnout, but also an indirect effects on the quality of care for those care recipients. Prevalence of depressive symptoms among caregivers really depend on the health conditions of care recipients, duration of care, and also caring demands or caring burden. International Systemic Review has reported the range of 20 to 40% of depressive symptoms among caregivers. And the highest are actually being reported for family caregivers, for patients with cancers, and also patients with dementia. So correlates or factors related to depressive symptoms could be quite complex. And that's really taking into account characteristics of caregivers and care recipients, but also their relationships in the family, as well as household arrangement within its cultural context. In the case studies of Indonesia, we're only going to touch this briefly as I'm presenting on behalf of our colleagues. So the healthcare side of coverage in Indonesia has improved over recent year. years, including the government scheme to implement universal health care. So the Ministry of Health has provided a range of care, also partly through the community health centers, and this including the curative and preventive care. But also the notably, there is a number of integrated care posts for elderly in some of the community health centers area. According to the pilot of the Silani conducted by the Ministry of National Development Planning, family care is still very common source of care for older persons. So in Indonesia, a range of studies has focused on impacts of family caregiving, but the majority of these studies have focused on specific type of diseases, specific types of illnesses for the older persons. Approximately 1/3 of caregivers for hemodialysis patients are found to report anxiety and depression, and also a study reporting a substantial depressive symptoms among caregivers of Parkinson's diseases. And these stressors are increasing as they cope with their family declining conditions. So what we look at is we look at relationships between older care recipients and their primary caregivers and households, and look at the factors relating to this. We use the data from Indonesian Family Life Survey, Web 5 in 2014. Our definition of caregivers is quite specific because of the data. So we look at those that are aged 50 years and older, and that's because they're starting having a functional decline. Those care recipients are the ones that reporting having functional limitations, then also they report requiring assistance with their daily activities. We use a range of variables, anything range from whether they can walk, they can dress, they can bath, they can shop, carry a workload, heavy load, and there's several variables which we aggregate to represent functional limitations of the care recipients. We also get information on their relationships and intensity, whether who care for them and how many days per week and how many hours per day as intensity. Our outcomes of the caregivers is a Center for Epidemiologic Studies on Depressive Skills. And for those that score 10 or more, that's reporting having moderate or severe depressive symptoms. Caregiver characteristics, we get information on age, sex, work status, education, rural and urban areas. And the variables related to caregiving that we look at is the care recipient functional limitations, co-residence or intra-household support. So this is whether they have received physical help from other members, household members. There's also information on inter-household support, for example, whether they're receiving any financial support from other family members, such as, for example, siblings who do not live in the households. So here we're just showing that the different patterns of primary caregivers been broken down by gender of care recipients. So over half of males reporting receiving their care from their spouses compared to the other way around, which is only 8% of females are receiving support from their spouses. The majority, the main part of support from female care recipients are actually coming from their adult offsprings, as well as their grandchildren. And that's much lower among their male counterparts. About half of care recipients report receiving low level of care, so that's only 30 hours per month, but about 40% reporting intermediate care and 8% receiving high level of care intensity. So about half of the spouses provide moderate levels of care, and about 10% of those report high levels of care intensity. So in the context of the time, we just present on the final result now. So the multivariable logistic regression model that we use to predict depressive symptoms, the bolded values are the one that's statistically significant. So about a third of our caregivers report having depressive symptoms. And actually compared to those that caregivers that work, those that don't work, and this already exclude those that are sick and disabled, report almost twice more likely to have depressive symptoms. Other main variables are having a lower education, living in rural areas, having a multiple older care recipients in the households. And that's actually quite common. They don't just have one older care recipient, sometimes they have two or more. And lastly, the functional limitations of care recipients are really determine the depressive symptoms 2 or 3 more times, depending on what level of that determine intensity of care. For those that not receiving household co-resident support, were also 1.3 times more likely to report depressive symptoms compared to those that have reported receiving support. So as I mentioned here, older males tend to receive support from their spouses, where older females, and actually in our data, it's also more likely to be widowed, report receiving care for their adult children. So the key factors that we found is what we know already: part of the low education, not having working status, rural residents, having care recipients that have medium or high functional limitations, having more than one older care recipients in the households, and not receiving support from co-residents. So these are the what we can interpret from the data, but in the larger context, there are also information that we haven't incorporated in, and it could be really helpful and useful to explain these symptoms, such as the length of care provided, and whether are there other family members, whether they don't have to be older, but they could be disabled or younger children, for example, that might actually affect the depressive symptoms for the caregivers overall. This is similar to what Professor Chan mentioned earlier, that there are also positive aspects of caregiving. They're not all bad. They also sense of fulfillment for the family, but we weren't able to capture this data. We also have reported some results in other studies in Asia, talk about the effects between social support and depressive symptoms among caregivers, which could provide further insights into the pathways. So interestingly, we found that caregivers not in the workforce were more likely to have depressive symptoms among compared to other caregivers in the paid work. And our plausible explanation could be that having paid work could reduce economic pressure in the household, as noted in the other IFRS study on noting the large informal workforce. So our studies also align with other studies in Indonesia that talk about females adults co-residencing with elderly household members were actually less likely to be in the labor workforce. Other qualitative studies have also shown that the role of social support could be very crucial for caregivers of patients, and the study look at the patient with schizophrenic conditions. And social, not only social actually, but also spiritual support were also reported to be vital for family caregivers in the context of cancer patients. We like to note that the depressive symptoms we use are self-reported, so this could be different in different cultural contexts, whether it's in Asia or internationally. We also note that the care recipients here, they are identified by their functional limitations, so the level of depressive symptoms that we have might be lower than other studies of the caregivers of cancers or dementia patients. So the implication for long-term care initially for this study is that they need a provision of the adequate social support, and this is as a buffer for their psychological health. We also look into the possibility of screening for depressive symptoms among caregivers, and actually the earlier it would be better to reduce the adverse effects. In the context of the book, we have started getting some information about the potential of potential role of community care in helping older care recipients and provide support for their family caregivers. We know that in the context of Indonesia, there's still a case of limited number of community health workers volunteering their service and limited resources in Indonesia. However, for other comparative study of ours, we also found similar challenges actually also for the local community projects in Vietnam, which provide volunteer healthcare services for older persons. And also in Thailand as well, we have a similar long-term project, which having the support and financial support in particular from local community would actually help with the sustainable projects. So I might just leave it here to say that we're still very beginning of the journey of doing these comparative studies, but implications, challenges, and lessons that we learned from the 3 countries could be shared and would be quite important. So these are my information, and I look forward to your comments and be able to share the results once the book is in progress. Thank you.
Thank you, Dr. Vasantara. You already explored different issues of research regarding dementia. And now it's our time for question and answer. Let me check is there any question in the chat.
Yes, Prof, here it is. Did you find my slide? We have 4 questions.
Who will ask the question? Please, would you like to direct your question directly to the speaker?
Please read the question and direct it to the speaker, please. Well.
No, I haven't seen any question. Susie, do you see any question? Well, meanwhile waiting for the question, maybe I would like to ask to Ms.
We have the question on my screen.
Happy to answer the question of Dr. Lilis. What's the important aspect to reduce risk, prevent dementia, and who has the higher risk to get dementia? Clearly, for the higher risk in terms of aging, there's modifiable and non-modifiable risk. I think both speakers can also add to that. So the higher risk is, of course, people who who's elderly, 60 above. But we know that there's young onset dementia and early onset dementia as well. That's affected by brain damage and familial Alzheimer as well. So in terms of the important aspects and reducing risks, of course, social activity or physical activity conducted regularly, as I mentioned earlier, on how physical activity is something that could reduce risk of dementia, engaging, volunteering, having meaningful engagement. I think in Australia, there was a campaign on ABC, Act, Belong, and Commit. And it's also mentioned by Professor Chan's speech earlier on reducing risk or preventing dementia is through having physical, from now on, as well as Ibu Nafsia mentioned, that we have to start early in preventing it, not wait until we turn 60 above. And in Indonesia, there is cerdik, cek kesehatan rutin, checking having regular medical checkups and engaging with social community. And that's why our member in Indonesia, Alzheimer Indonesia, and actually in Thailand as well, have support groups for caregivers that have to experience depression and burnout and all these aspects. So following up to the second question, if you don't mind, Professor Hadi, Pak Hadi, from Sabnan Santos, Universidad San Francisco de Quito. The requirements for a country to become part of Alzheimer's Disease International is actually because of Alzheimer's Disease International is civil society. So it's the requirement is having all the paperwork as an official civil society that is registered in the country. And also I'm happy to invite certain countries who has not been a member of ADI, but the requirement is actually one country has one association, and if there's many others in the country, it could collaborate in terms of their role or what they can contribute. So if more information, you can go to our website www.alzint.org. Or you can simply contact me directly as well at dy.soharia@alzint.org. I think there's another question from my friend in the Philippines, Shelley. It's for Dr. Suyono. And so I'm sorry, I'm just reading all this and passing it on back to you.
Okay, okay. Thank you, Ms. Suhaila, for the response. And I will go to Dr. Suyono. There are two questions. Please respond.
Okay. Hi, Professor Shelley de la Vega. So regarding the hearing loss, yes, I do believe that biologic plausibility of this issue towards dementia. As we have already know that the stimuli towards the brains is a very crucial point. The stimuli is not only for the ones that who can read or ability to engage in several encounters using their eyes, but also hearing is also one of the point of input of the stimuli. So it is quite a very crucial point. People with hearing impairment could be experience dementia in later life. Specific data from Indonesia has not already been recognized at the moment. So I think this is a very good starting point to have the screening, hearing screening, and let's look the long-term effect of the hearing loss problem for dementia. Thank you for the insight, Professor Shelley de la Vega. And from BKKBN, from Ibu Mardiana Dwi Puspitasari, regarding the long-term memory. Actually, it is the short-term memory that could be the early sign of cognitive decline. But up till now, we still have the all kinds of memory that correlates with the cognitive decline. So to make a certainty of this issue, I think it would be worthwhile to have a screening by doing the MMSE examinations, for example, or Minicoc Indonesian versions, the more easier way to screen the cognitive decline. I think this screening instrument could also be obtained even in Puskesmas or in the primary health centers throughout the country. Thank you, Prof. Hadi.
Is there any more question?
Yes, we still have one more question for Prof. Fasun.
Oh, yeah.
Okay. Yes.
Sorry, I couldn't see the screen.
Okay,
I didn't see the
screen. Yes, here it is. Can you see my screen?
Not yet.
I think it's coming.
Yeah, it's coming.
No, not yet.
Okay, I will repeat it. Can you see it?
Yeah. Can you see Dr. Fasantara?
Yes, I think I just saw that they're coming out. Yeah, what are the most worrying? I just want to make sure that I understand the questions correctly. So these are, what are the most worrying consequences of older adults that are taken care of? So this is, for example, the spouse, I imagine. So if the older persons, for example, would be their spouse, their female spouse, their wife, there are two parts, basically. If they're not, as I mentioned, the direct effects would be their health in themselves would getting worse, the care recipients, the caregivers' health would getting worse, but these also have effects on, if they're not doing well, they actually could have effects on how they care for their care recipients as well. In addition, this, as we mentioned, that the females were more likely to be widow. So if they themselves not care for their own mental health, they, in the next couple of years, they could also be care recipient themselves, and that care burden could come down to their adult offsprings or their grandchildren. So I think that's the main part of it has an effect not only for themselves, care recipients, but also in the future themselves could become a care recipients. So the cycle continues. What the family can do, I would say that there will be two parts, because as we see that the health within a family is a buffer or protective of the psychological health of the caregivers, I think having that support is very important. I think also, as the other speaker also mentioned, that there's also other groups in the community that can really help them going through something similar. So other caregivers association, for example, could really help them to minimize the effects for themselves. Lastly, respite care can also be quite important. Having some break from providing care can really make difference in their psychological health. So to the moderator, that would be kind of my comments. Hope that makes sense.
Okay, thank you, Dr. Vasantara. Is there any other question, Susiana? I didn't see the...
Okay, I think we have finished our time, Prof. Let's jump to the summaries.
Okay, then let's go to the summary. In this symposium, Ms. Suharya emphasized that dementia cases become increased around the world and including in Indonesia, and it is necessary to all society to committed to support to the 7 action areas of the Global Dementia Action Plan by strengthening partnership and also emphasize the national action plan. And luckily in Indonesia, we have already the action plan. And then Dr. Sesna, he discussed that dementia is not just a cognitive decline. There are cognitive functional problems. There are also functional disability and also problems of morbidity. And lastly, Dr. Vasantara explore the issues of different research and also the aspect of the economic of the dementia care. And Indonesia is put as one of the study in which the family is still most common caregiver. And by summarizing this plenary symposium, I would like to close, and again, thanks to all the participants for joining this symposium and also for giving some question, and also again to our panelists, to Ms. Suharya, to Dr. Sesna, and Dr. Vasantara. I appreciate all of your sharing in this session, and thank you for Susiana for willing.
Thank you, Pak Hadi. I'd like to just appreciate Ibu Nafsia here, who actually, because of her leadership, that trusted our civil society, she stepped up and support the first time the task force of dementia plan that started in 2014. So Ibu Nafsia, thank you so much for your support and political will back in the past in supporting dementia. Thank you.
Thank you so much, Prof. Hadi, Dr. Heriawan, Dr. DY, and Dr. Fas. Thank you very much for your sharing. And we reached our last session. It's a photo session. To all participants, would you please open your camera? And I will check. We have 3 slides, and we will open. Please open the camera, and I will take the pictures of our today's session. Okay, shall we start? 1, 2, 3. Hang on. We'll go to the next slide. 1, 2, 3. And the last slide. 1, 2, 3. Okay, thank you very much. And let's move to our main room, and because we still have a closing session there for today's session. Thank you very much, and see you again.
Thank you.
You may leave the breakout room, or it will be closed automatically in 50 minutes. 50 seconds, sorry.